So I wanted to talk a little bit about therapeutic nutritional ketosis with respect to the use supplements, because our patients are using a ton of supplements all the time. And everybody wants a simpler way, a more effective way, a quicker way. It's just our very nature. And so, unfortunately, we're not going to get away from that. We're not going to suddenly wake up tomorrow and have our patients say, oh, I'm going to do the standard thing and everything will be all right. Because they spend so much of their time shopping the internet. They spend so much of their time gathering the information, and it's human nature to try to figure out a more efficient way to do something. So in that vein, I wanted to make sure that we knew what they were seeing, and there is some value to some of these supplements. And so I wanted to talk a little bit about that, because I found that if I ignore that part, what people's desires are in the practice, they're going to do it anyway. And then I have to end up guessing what they've done, and then have to answer the question anyway. So that's why I wanted to kind of have this discussion, because I think that the patients use supplements, and we're going to have to adapt to that. A supplement is really anything that we add. In the United States, we really look at it as a dietary supplement, but supplement could be anything. About half of the US population currently uses some form of dietary supplement daily. The thing is, in the US, there's a particular guideline, it's called the Dietary Supplement and Health Education Act, which prohibits the supplement manufacturers from making a health claim. So you'll notice on every supplement that you see, they're not making a claim to cure or treat any disease. And that's by the very nature of the Dietary Supplement Health and Education Act, which actually gives them some degree of immunity from prosecution should something go wrong. That doesn't mean that the supplement is innocuous. That doesn't mean that the supplement doesn't work in some way. It just means for that particular thing, because it's a dietary supplement, it's taken care of through the Dietary Supplement Health and Education Act, and they can't make that claim, and they get some protection for that. So the issue that they found is that a lot of supplements are adulterated, they're contaminated, they're mislabeled. And that can be a major problem, because some of these supplements contain extraordinary heavy metal compounds, arsenic, cadmium, lead, mercury. And so you really want to, if you're having a conversation with your patient, you want to point that out to them. Just because they've got a supplement and they think it's doing XYZ, it may not be, and they may be cross-contaminated. There's supplements you're going to find that are listed as protein supplements. And the reason why they're listed as protein supplements is because they have a large amount of nitrogen. But the way that it's worked out, they're measuring the nitrogen, and it turns out that it could be formica, because that produces a large amount of nitrogen on the testing methods. There's some of these supplements, especially some of the yerba mate and some of the other things, depending upon the extraction technique, you may end up with arsenic, you may end up with lead, and you never know. Some of the supplements, especially the colorants, you can end up, like for example, berberine, which is incredibly cheap, but there have been berberine samples that ended up with basically car paint, because car paint looks dark yellow, and it was easy for them to manipulate that. And so quality of a supplement is relatively important, and the origin of the supplement and the testing behind the supplement is also relatively important. I'm not going to be talking about that in this conversation. This conversation is to talk about the supplements that patients use, but keep that in mind in the background. And there's tons of information on, which companies are better, which companies are worse, but that's not what my point of conversation today is. Supplements can be over the counter. Supplements, in fact, when we supplement people with something that's over the counter, but we also prescribe it. For example, we can prescribe Vasepa, which is EPA and DHA, but it's essentially fish oil, and that's a prescribed supplement. We can have supplements that are non-medications. So supplement just means something in addition to. It doesn't necessarily mean purely dietary, although that act that I talked about was specifically dietary. I would almost akin this to people trying to biohack themselves. And I know that the term biohack is pejorative, but it's how human nature is. So I'm going to start off with some of the the things that I get most commonly asked in therapeutic nutritional ketosis and what their particular value is and my particular approach to it. And this is meant to be as a discussion rather than oh, you got to do this. These are some of the most common things that I deal with and what the rational basis behind it is and what the thoughts are. One of the most common supplements that I get questioned about is berberine. And berberine is used as an analog for a lot of people because they use it as an analog for metformin. There's a lot of literature out there that says that it helps as in terms of longevity. It probably works in the mTOR pathway, but my suspicion is that it reduces insulin resistance and it stimulates glycolysis. It has there's some really good studies on it, which it prevents the formation of adipogenesis. It reduces the formation of fat cells, de novo fat cells, and independently also lowers LDL-C and triglycerides. I think it's working primarily on gut microbiome, and it's working in the presentation some of the carbohydrates, primarily fructose, to the liver, akin to how metformin works. There is not a clear-cut answer to this, but berberine's been around for a long time, and it's one of the safest drugs that we know of. It's been shown to have some benefit in non-alcoholic fatty liver disease. It's been shown to have an anti-diabetic effect. It's been shown to have benefits in gout and obesity, and all of these things are interrelated. They're all metabolic diseases of hyperinsulinemia, and there's some discrete benefits to it. The typical way that I explain to patients, if they're interested, is that berberine is effectively extending their period of essentially fasting window. So if they use a supplemental berberine 1,000 milligrams, what it's doing is it's extending the fasting window by creating a time period that it's creating the milieu for increased glycolysis and increased lipolysis, and it keeps them from feeling hungry. There are some studies that on animal models that it shows that it increases longevity. Another common supplement that I get asked about is vitamin K2. Vitamin K2 has a lot more discrete data that documents that there's some significant benefit to vitamin K2 and calcification in coronary artery. It seems to resolve coronary artery calcification, and there's a discrete mechanism of action that has to do with osteocalcin, that it activates osteocalcin, which is the protein that promotes the incorporation of calcium into the bone, which then shifts the calcium out of an atherosclerotic plaque. And there's some studies recently that show 12 to 15% change in the thickness of calcification, even over 4 to 6 week use. So there are some pretty good studies, and I've referenced some of them in the notes section that you'll find if you download this presentation. But it does seem to definitely reduce interval calcification and atheroma formation. And it's a relatively low risk. It's not something that is going to cause you a tremendous amount of mischief. And I don't think that vitamin K2 is going to become a pharmaceutical, because none of the pharmaceutical companies have been able to rebrand it into something that they can sell independently. Berberine's been around so long that they really can't rebrand it and make it special. And same thing with vitamin K2, they can't really rebrand it. It'd be like branding sunlight. You're really not going to be able to do that until you come up with some proprietary mechanism of action that's unique for your pharmaceutical. But so vitamin K2 seems to be beneficial as in terms of overall health, and as in terms of our patient population that's trying to do therapeutic nutritional ketosis. It's not a negative. It's not a carbohydrate. It's a fat, and it's not a negative. It will not throw them out of ketosis, and neither will berberine. Berberine will extend the ketosis rather than diminish the ketosis. Another thing that we frequently deal with is vitamin D supplementation. And I think that vitamin D is far more than just a vitamin. And we all know that. I mean, we all consider vitamin D as an endocrine compound, but I think it's even more than that. There are some really good studies that show that vitamin D supplementation, even at moderate to high dose, close to toxicity levels, actually reverses schizophrenia. We've shown that it reduces suicidality. And there was just recently a VA study that showed a 50% reduction in suicidality with vitamin D supplementation at a moderate to high dose. That's a big deal. It also reduces suicidal urges, which is really interesting when you do some of this psychometrics. I work and operate a pain management center, and behavioral health is inherently a major part of our pain management center. And we're constantly looking for clues of patients with suicidal risk. And we're constantly also looking at all of these other elements, and vitamin D is something we're very sensitive to. Unfortunately, one of the things I've noticed is that there's been a change in the laboratory testing for what's considered a low level. It used to be 35 to 40 was the low level, and now they've gone down to about 25. And so because our population is more and more vitamin D deficient over time, the normative value has decreased. And so you may not be able to prescribe it because it won't meet the hypovitaminosis diagnosis, but you can still supplement it orally and have the patient pick it up like 5,000 IUs or something in that neighborhood per day. Vitamin D reduction is not just because the patient's not in the sun, it's also because a lot of the processed food that these patients are getting leaches the vitamin D out of the system, and it prevents them from maintaining a high level. That's one of the things that I talk to patients about pretty frequently. Another compound is yerba mate. Yerba mate it's a stimulant. It's a theobromine. It's a theophylline, and it's been around forever. It's a polyphenol, so it has an antioxidant property and it's an anti-inflammatory. But the biggest thing it is a mild to moderate stimulant, and it's been shown to reduce cardiovascular disease. It's been shown to reduce stroke risk. It's been shown to reduce LDL-C, but the studies aren't huge. And because it's such an old drug, there's not a lot of people that are going to be doing significant studies on it. And because it's doing this without doing a high amount of caffeine, patients aren't like feeling nauseated. They don't feel shaky. The theobromine does not make them as agitated or nauseated as they would if they had taken, a couple hundred milligrams of caffeine. The average coffee cup has about 80 milligrams to 100 milligrams of caffeine. My yerba mate patients take 900 milligram capsules, and they take 2 or 3 of them. We know that over the course of even just a few weeks, in combination with dietary intervention, these patients end up getting their non-alcoholic fatty liver disease, their liver congestion, their GGT levels start to drop. And so there is a discrete benefit. That supplement for us is worthwhile because as it does that, it also seems to cause some degree of satiety. It keeps the patient from feeling incredibly hungry, and it gives some degree of buffer, especially initially. A lot of our patients, when they go into a dietary intervention, their biggest fear is, I'm going to be hungry. They quickly realize that, no, we've got methods to prevent that hunger. Green tea extracts, or the catechins, it's almost more the function of the actual catechin rather than the stimulant that's giving you the biggest benefit. And so that's one of the things that discuss with my patients. EGCG decreases ghrelin levels, and ghrelin is something that normally stimulates hunger. Certainly, green tea extract has some caffeine in it, but it's really some of these other compounds, the catechins, that have a whole host of other effects. Caffeine independently has a lipolytic effect. It mobilizes fatty acid and makes them more available for use. And it certainly is one of the things that increases the amount of ketones. But there's an independent effect of just these green tea extracts that seems to directly affect liver health. And it's beyond just the simple antioxidant properties of it. Green tea has been used forever. Your patients may be already taking it, may not even think of it as something that's special, but it certainly keeps them from feeling hungry. Omega-3s. The thing with omega-3s is everything within balance. In the US, most of our patients get an excess of omega-6 seed oil. And that's a seed oil that quickly, in the presence of fluorescent lights, quickly in the presence of heating, quickly becomes a trans fat. And it also typically, independently, is somewhat addictive. And we can't, as humans, tell if we're eating a rotten omega-6. Omega-3s seem to have a protective effect, and they also are pretty sensitive to heat. They're also pretty sensitive to light. And so we typically recommend that you store your omega-3s in the fridge so that they're not exposed to light, they're not exposed to heat. And the thing is that omega-3s, we can tell when they go bad because they smell terrible. They smell like dead fish. Omega-6s, we can't tell as human beings or as a rat population, can't tell that they've gone bad. And we actually are somewhat programmed to enjoy the taste of rotten omega-6. There is a compound that is an anandamide-like compound that gets generated by cross-linking of omega-6s. And it almost a compound that makes us feel good for taking it, but at the same time, we're being exposed to oxidized linoleic acid in a huge way. And that's the compound that is associated with cardiovascular disease, and especially foam cells that are accumulating all of the damaged materials. So a lot of my patients ask about omega-3s, and we typically recommend that they use krill oil because krill oil has a astaxanthin in it, which is a terpene. And that terpene in my patient population is beneficial because is a anti-inflammatory and it's useful for pain. And I run a pain clinic. And so it's one of the terpenes that, similar to a lot of the terpenes found in marijuana, that has an adjuvant effect. It's what gives krill oil its red color. GABA is another supplement that a lot of our patients talk about. And GABA inherently it's an inhibitory neurotransmitter. It's one of the main inhibitory neurotransmitters and allows hyperpolarization of the cell. It's almost the exact opposite of glutamate. It allows an increased permeability to chloride ions and hyperpolarizes the cell, and it decreases neuronal excitability. The thing with GABA is that we're awash in everything that's glutamate. A lot of our food contains glutamate, and glutamate is something that's added to food to keep us from realizing that it's rotted. And GABA is the exact opposite. Glutamate is an excitatory neurotransmitter. GABA is an inhibitory neurotransmitter. GABA is especially useful for in the population that I'm dealing with because it promotes sleep. And it does it in a couple different ways. It works directly on the gut microbiome, feeding the gut microbiome and stimulating vagal transmission, but also directly when you ingest GABA, it directly is hyperpolarizing cells. And if you take it for a while, and I'm talking about 2 to 4 weeks, there seems to be a pretty significant change in anxiety level. There seems to be a pretty significant long-term change in heart rate variability. And these are all positive things. And so I have a lot of my patients, especially when they're entering into ketosis and when I'm managing them, I supplement them in combination with a good sleep hygiene protocol with a GABA supplement. And there's a whole host of them that we use, but it does seem to give a lot of benefit. And if you feed the gut microbiome correctly, you're going to create a situation over time where that population of bacteria are promoted. And it makes it more likely that you're going to have that set of bacteria around and increasing their numbers. Tyrosine is another relatively simple amino acid. It's not an essential, it's a non-essential amino acid. It's made from phenylalanine. Now, there's a couple of things about tyrosine that I find interesting, and the reason why I end up having discussions with patients. I would tell you that 35 to 45% of my patients that come in have ADHD or have been diagnosed with ADHD. A lot of them have been on some form of stimulant. They've been on stimulants like Adderall or other things. And I don't know if other people have noticed this. I have, and in my particular practice, because I deal with hedonic issues, I'm dealing with hedonic substitution. I've noticed that patients on ADHD meds become anhedonic over a very short time period. And part of that is related to a dopamine depletion. It correlates pretty well with the risk of Parkinson's, because Parkinson's is also seen in patients with long-term ADHD meds. And we think that it's related to a dopamine depletion in the substantia nigra. And we think that there may be some value to giving the precursor amino acid that helps form that dopamine. And I've noticed, and again, we're talking supplements here. There aren't like amazing studies that say, okay, this is exactly how this works. We have the mechanism of action and we have the correlative in pieces of information. There seems to be some benefit for these patients that the tyrosine is giving them some degree of hedonic stability. Also, it's a precursor for epinephrine and a lot of the thyroid hormones and melanin. There have been some good studies that show that it helps reduce stress and improve memory. And there's no negative as in terms of supplementation in a ketogenic diet. And in fact, if you reduce their stress responses, adaptation to ketosis is a lot easier for some of these patients, especially the ones that may be already depleted of dopamine because they've been on ADHD meds. A lot of these patients come in and they have dysfunctional thyroids anyway. And so this also seems to facilitate their thyroid function a little bit better. I see that more in the patients that have normal TSH, but they still feel clinically hypothyroid. They feel blasé and they feel clinically hypothyroid and their TSH looks normal. And you wouldn't normally supplement them with thyroid hormone, but you could. And I usually try a round of tyrosine because sometimes that's all it takes. And that's a little bit, I can justify it a little bit easier than I can giving them a thyroid supplementation. So there's a lot of conversation about microbiome, prebiotics, probiotics, fibers, non-fibers, everything under the sun. My general statement to patients is, look, if you're eating a generally healthy meal and you have the appropriate precursors for most of what you need, I'm not going to tell you to go supplement with a prebiotic or a probiotic. I do think, though, that if you come in with a damaged gut, I do think that if you have bloating, if you have histamine release issues, if you have all of the other things, then for a specific individual patient, there is probably some specific benefit to a prebiotic. There is probably some specific benefit to a probiotic. But most of the time I tell them, look, if you're just taking probiotics to take them, you might just be wasting your money. And one of the key elements that I strongly advocate for them is, look, also recognize that if you are doing a stool sample and you measure your stool population, that doesn't mean much. The stool population changes minute to minute, centimeter to centimeter in the gut. It literally changes in real time. And it's so based upon the interaction of your sympathetic and parasympathetic system, your circadian rhythm, what you thought of 15 minutes ago and where you are now. So the discrete single sample, even a genetic profile at a given moment, doesn't give you a true measure if you should be on a probiotic supplementation. And so I typically am less encouraging of patients to spend significant amounts of money on doing probiotic supplementation, although I don't have anything against it. I'm just more sensitive to telling them, look, I'm not sure it's going to work necessarily the way you think, but I'm not going to say don't do it. But it's not going to give you the dramatic effect unless you truly have a defect and you've managed to sterilize your gut because you took a bunch of antibiotics, or you managed to have a histamine release issue, and you have some other clinical issue of significance. Arginine citrulline. So we have a rampant issue in our US population. It's called impotence. There's a couple factors for impotence. One of them is that the vegetable oil that we consume destroys the endovascular structures and it creates increased rigidity in the vessel walls. And simultaneous with that is that leads to a reduction in nitric oxide formation. Arginine citrulline will help restore some of that blood flow. It will help restore some of those functions. Nitric oxide is one of the most potent vasodilators that we have. There's a whole host of ways that we can get to the right place as in terms of nitric oxide formation and how to deal with blood flow and athletic performance. There is some benefit for it, and it has been shown that if you increase nitric oxide formation, it may improve athletic performance, but it's not going to do it at rest. It's not going to be you take some nitric oxide and all of a sudden you're going to be buff. BMR is going to go up because you have hypertrophied muscle, because you have more vasocongestion. But arginine is a supplement that we discuss quite frequently within the context a lot of the other problems that I see in these metabolically injured patients. And impotence is one of that's why we have all these men's health clinics popping up everywhere, because this didn't even exist as an issue to this extent 25 years ago. It's really an acceleration because of the intimal damage that we're creating through our dietary intake. We have patients that take arginine citrulline. I usually use it more for my athletic patients, but I also use it for my non-athletic patients who are very sensitive to this and are in the process of changing their lives, and they want to do everything they can to restore their health. And when we take a sexual health history, this is one of the things that frequently comes up. Creatine is a very interesting compound. Creatine historically has been used as a compound in bodybuilding and increasing the muscle mass. And historically, we've looked at creatine as just some compound that bodybuilders and bro science talked about. They would take 5, 20, 50 grams. They would take enough creatine till they had diarrhea. And that was what they were using to look like they were buff. And a lot of people in the regular science fields, we look down upon it saying, they're not doing anything. All they're doing is they're increasing the edema in their muscle. Well, that's not true. We found out that was wrong. What's happening is you're actually creating phosphocreatine, and phosphocreatine is a stabilizing force and allows a long-term production and a buffering effect for ATP formation. Because as we sit, we only have a few seconds of ATP at any given moment. And if I took cyanide right now, I'd be dead in about 5 seconds. I might get an extra 3 seconds if I had a bunch of phosphocreatine, but it's an additional buffer that's not insubstantiative. And the thing is, it has just as much effect in our central nervous system as it does in the muscle that we have. And so I really use creatine as a supplement for a lot of my patients that have some degree of cognitive decline. And I'm using that as a supplementation in combination with a ketogenic diet to improve the effectiveness and bypass the entire insulin glucose cascade. So I give them ketones, I supplement them with creatine, and the creatine doesn't throw them out of ketosis, and it makes them more cognitively sharp. And at the same time, I'm encouraging them to try to get away from their sarcopenic wasting. And that certainly makes them feel better. And it seems to give them better stability. And we can talk about dosing on that if anybody has any interest. But it's interesting because bro science was right. It does have a very significant benefit that we just didn't recognize. Exogenous supplementation. There's a whole host of thoughts behind exogenous supplementation. And I don't really use exogenous supplementation except a few circumstances. If I am trying to prime a pathway and the patient's not used to ketosis and they're struggling with it, I might use some ketone salts. I mean, they taste terrible, but I might use some ketone salts to improve the pathways so that the body starts to recognize that that's a pathway that it can start to use. I also use exogenous ketones as a quick test in patients who have cognitive impairment that are sitting in nursing homes. When you go in nursing homes and you go onto these wards, there's a ton of sugar there. And these patients are jonesing for sugar. I mean, I've been there and they're literally Pac-Man running around trying to find more and more sugar. And I use those exogenous ketones as a very quick test, because if you give them a shot of exogenous ketone and all of a sudden they perk up in 15 minutes and they know where they're at and they know who you are, it's almost dramatic. And you know what you can get back. You know where you can go with this. And you can help the patient and the family realize that it might be just this dietary sugar they keep consuming and the nursing home keeps feeding them. And so I use that as a priming method or as a quick test method. And certainly, if I was having somebody who had migraneous headaches, if I had somebody who had seizure disorders, and I was doing therapeutic ketogenic diet for that purpose, and I wanted to get up over 2 millimoles, yeah, that's going to be a great way to do it. And if you're doing deep dives and you don't want to have a seizure, yeah, the exogenous ketone supplementation is the way to go. But as in terms of a routine supplementation, I don't find a lot of value to those exogenous supplements, but patients will ask about them all the time. Up front, I'll let them do it because it primes the pathway and it keeps them from feeling hungry. It actually makes them immediately satisfied. What I don't like to see is they supplement with ketones and then they still eat the sugar. You have to explain to them, look, this is not magic. You're not in ketosis if you're still consuming candy bars and you took this exogenous ketone supplement. That's not the therapy that we want you to go towards. Okay, MCT oil. We do use a fair amount of MCT oil. We're not recommending bulletproof coffee. We're not out there saying, hey, have a bunch of extra fat just so you can increase your ketones. But MCT oil is rapidly absorbed. It's quickly metabolized. A C8 form is amazing, and it definitely gets your ketone levels up, boosts the ketone levels in your blood. And that's a simple way to do it. And it is very effective, especially for somebody that's trying to get into long-term high levels of ketosis. And it primes that pathway much, much quicker than any other that I found. And it's more palatable than a lot of the ketone salts. The downside of MCT supplementation, though, is significant diarrhea. And so that's, you almost universally, if you get to the right level, you're going to have diarrhea. And it can be quite troubling for the patient. But they quickly figure that out. Electrolytes. That probably is the most important supplement that you can deliver to these patients because they historically have looked at sodium as the evil thing. And they do everything they can to be on a low salt diet. You get somebody into therapeutic ketosis and they're starting off and they're avoiding salt and they're a little bit older and they have a history of atrial fib, I guarantee you're going to go to the emergency room. I guarantee you that patient is going to be having a discussion with an ER doc who's going to be calling you and asking you why it is that you put this patient into an abnormal cardiac rhythm and how you did it. And then the thing is, a lot of these patients, as we start ketosis, they start to shed that sodium, and a lot of them are on diuretics. And they forget to tell you that they're on a diuretic and they become hyponatremic. A lot of them will start to shed that potassium, and that's another problem. Magnesium is another supplement. I usually use it in combination with GABA, especially at night, because it itself is a slightly inhibitory neurotransmitter. The GABA is inhibitory neurotransmitter, and the magnesium aligns with that pretty well. It's involved in a whole host of energy production methods, and it reduces the symptom of keto flu. And so I supplement with that. One of the supplements that I was initially missing, and I only discovered this incidentally when I tried to figure something out, is zinc and copper. And the only reason I discovered it, it was especially important in my patients that were doing daily sauna or every 2 or 3 day sauna. We know that sauna therapy reduces cardiovascular disease, at least in the finished studies, by 50 to 60% with patients doing sauna for 3 to 4 times a week. One of the key elements, though, is you have to have a diet that's high in zinc, because if you don't, you're going to get low zinc levels pretty quickly. And when you supplement with zinc, you need to supplement with copper. And that was something that it was an incidental discovery. And I should have recognized it right up front, but you'll find patients get incredibly agitated who are really pushing it and using sauna all the time. And they essentially, in their sweat, they'll pour zinc out. And there's no other way for them to get it. You have to almost supplement it in order to do that. Magnesium is the one that I will long-term put them on, because the sodium, they'll auto-regulate. They'll realize that they need to eat more sodium. And if they're eating a lot of carnivorous diet, they're going to get enough potassium and they're going to be okay. But magnesium is something that I would tell you that the majority of my patients are deficient in. And our magnesium testing is relatively insensitive to that. The symptom that they're going to exhibit is cramping in their legs. They're going to exhibit a lot of muscle cramping. They're going to have a lot of difficulty sleeping. It's almost going to look like restless leg syndrome, but you give them a little bit of magnesium and you can avoid the requip. They're going to get contractility and almost fasciculation of their muscles. You give them a little bit of magnesium and it's going to go away. It's something that keep in your back pocket when you see that, because it's something that can really benefit the patient, and it's very, very inexpensive. Digestives, bile salts, digestive enzymes. There's a whole host of things that can be beneficial for patients. It really depends on the individual patient. Do they still have their gallbladder? Have they lost their gallbladder? Did they have some issues with a fatty liver already? Do they have issues with fat intercalation into their pancreas? How far along are they? Is there enough blood supply to their pancreas that the pancreas isn't congested and doesn't have a localized high glucagon level? And because if you have a localized high glucagon level in the pancreas, it's not going to produce as much insulin. And if it's not producing as much insulin, it may not be producing very much digestive enzyme either. So there's a whole host of reasons to look at that, but I really tailor that to each unique individual patient. And the typical symptomatology is I'm looking at gut health, and I'm looking at nausea, I'm looking at steatosis, I'm looking at those kind of symptoms to make a decision. And you're not going to find this in a textbook that says, I look in my GI textbook going, well, what does somebody on therapeutic nutritional ketosis need to benefit from? You're almost becoming more looking at the functional aspect of that specific patient to see if there's a benefit. Vitamin B, there's at least 8 forms of vitamin B. 3 of them are dependent upon MTHFR genes, B6, B9, B12. All of these can have issues in patients for therapeutic nutritional ketosis. They can be deficient on all of them. And so you really need to look at the clinical symptom for each one of them. Each one of them has a significant impact on carbohydrate metabolism, and each one of them can have a major issue. And our blood testing is relatively insensitive to them. And so it's a conversation that you have in real time, trying to back into it. Now, there's certainly some of these vitamin Bs that have discrete functional specificity, and we can say, okay, this is going to be important. For example, thiamine's needed to build, it's a detoxifying issue. It helps recycle vitamin K, and it helps recycle folate, and it's part of our antioxidant defense mechanism. And if you're thiamine deficient, you're going to have symptoms of tingling, weakness, numbness, pain in your hands. You're going to have symptoms of peripheral neuropathy. I see this every day, and I'm never really sure whether it's a B1 deficiency or whether it's the 5 other things that patient might have. A lot of them will have some cognitive impairment. So my general approach to vitamin Bs is to supplement with vitamin Bs in general, and be particular about the ones that need to be methylated, because if they have an MTHFR deficiency, I certainly don't want to give them an unmethylated form of vitamin B, because I'll get a false accumulation and you can actually get toxicity. And so I have to be sensitive to that. I don't necessarily run an MTHFR screen on every patient unless they've had a lot of obstetrical history or they've had a strong family history. If they've had a lot of obstetrical history and they've had a lot of spontaneous abortions, then I'm thinking about MTHFR deficiencies. Riboflavin, it reduces your risk of getting an iron deficiency anemia. If I have a patient that comes in with microcytic anemia, this is what I'm thinking about, and would go off and look at that. But my first goal will be probably just to supplement them and see, because it's not going to harm them. It's water soluble. It'll go right out through the urine. So if they don't need it, they don't need it. But there is a significant benefit as in terms of improving the efficient use of ketone bodies, and it helps consumption of fatty acids. The clinical finding is that the outer edges of the lips, the outer edges of the mouth become swollen, they become red, and they become itchy. It's something that, and frequently you'll see some candida infections. But what I generally find is they just don't feel right, and they have a little bit of iron deficiency anemia. And that's typically the presentation that I see. Niacin is it's coenzyme. It's needed for energy transactions. And it's especially important in patients that are consuming a moderate amount of alcohol. If you're severely deficient, it's called the 3Ds or the 4Ds: dementia, dermatitis, diarrhea, and then the fourth D is death. That's what you're looking for. But it's kind of nondescript. You're going to back into this diagnosis, and most likely you're just going to be supplementing with vitamin Bs in general. Pantothenic acid is another vitamin B, it's B5. It probably helps in the metabolism of ketone bodies. It promotes energy utilization. Typically, what you see with this, if you have somebody who's vitamin B5 deficient, we see this in patients who are diabetic, who have terrible wound healing. Again, get around it by supplementing with vitamin B. It's pretty cheap. Pyridoxine is MTHFR deficiency dependent. It's critically important in the formation of a lot of neurotransmitters, and it helps in the formation of protein or degradation of protein. And it helps as in terms of periods of caloric restriction. And especially if you're supplementing with a ton fat, you need vitamin B6 to help degrade the fat. The thing with B6 is you're going to see anemia. That's the most common. But the other thing is insomnia. These patients have terrible insomnia. And the B6 levels on the blood testing are pretty accurate. And I'm extremely careful when I'm looking at that to make sure that there's no MTHFR deficiencies. And it's something that you have to be pretty sensitive to. Biotin B7 is a coenzyme. It's involved in gluconeogenesis. It's especially important in patients that are alcoholics. That's typically where you find a lot of these deficiencies as in terms of biotin. It's also, you'll notice in patients that are losing their hair, and you do a biotin supplementation and all of a sudden they get thicker hair. I'm usually pushing them to go get some horse shampoo because that's a high amount of biotin in the horse shampoo, and it's a cheap solution. B9, which is folate, you need that for repair and synthesis of your DNA. It's required for methylation reactions. And that's probably one of the most common deficiencies that we see. And it's often associated with reflux. It's often associated with significant GI dysfunction. Cobalamin is another one. It's required in the synthesis of DNA and RNA, and it's frequently seen as deficiency in type 1 and type 2 diabetes. Hydroxymethylbutyrate, HMB, historically is a supplement that has been used in the bodybuilding world. And a lot of patients will come in and they've heard about it, and they're using it because they think that they're going to increase their muscle mass. It does seem to increase their muscle mass. It's a metabolite of leucine, and leucine is a necessary amino acid. If you have leucine deficiency, you'll get fatty intercalation in your muscle and you'll get muscle degradation, and which is pretty common in the US. You get a ton of sarcopenic wasting with fatty intercalation. And we think that a big chunk of the population may have some mild leucine deficiency. It's that portion, it's the HMB component that seems to help. It does not throw you out of ketosis. And that question's been asked to me repetitively. And so it's a conversation that I have, especially if I have somebody that's trying to build muscle mass. It's something that I recommend for them and dose them up on it if needed. L-carnitine. What it does is it allows the breakdown of long-chain fatty acids and allows them to go into beta oxidation and be transported into the mitochondria. If you have an L-carnitine insufficiency, you're not going to be able to break down some of those fatty acids. Now, the thing is, if you have an L-carnitine insufficiency, you're probably not going to do well with a ketogenic diet. And if it's a hereditary L-carnitine metabolism deficiency, you could end up with a seizure. And it's actually probably an absolute contraindication for you to be on a ketogenic diet, even with a supplement. So it's something that if you know that somebody has a carnitine issue and it's a genetic defect, that's something that raises a red flag for me. And that's something that you kind of want to map out with their metabolism. Now, if they're just using it to improve their sense of well-being, yeah, it works, but it's not something that I recommend. But I've been asked enough about it that I think that it's something that I have in the back of my head when some of my patients are asking about it. Well, will it benefit me? I read that it would help. It might help. It'll make you feel less fatigued. More rapidly transfers those long chain fatty acids into shorter subsegments. but it's not going to magically make things better. Taurine, this is an interesting compound. And I think that we're going to talk a lot more about this in the future. This may be one of the best. I would put this up there with berberine as in terms of functional use. This compound is an osmoregulator. It determines where the potassium, sodium, and calcium goes in the cell, and it helps maintain cellular integrity. It has a potent anti-inflammatory action. It's an antioxidant. It's found in bile mostly. But the real issue with taurine is that it seems to increase lifespan. It does this through preventing senescence, and it increases muscle mass. And it's one of the few compounds that probably lengthens life without pissing the animal off. I mean, I can deprive you of carbohydrates, I can deprive you of nutrition, I can starve you, and you might live a little bit longer, but you're going to be real pissed off. Taurine allows you to have a mouse that lives longer with a longer health span, but they're not looking like they're starving to death. It creates some significant stopping of senescence. It also creates some epigenetic changes. It works in the worm model, and it works in the mammalian model. And we think that it probably has some benefit in the human model. It definitely does reduce abdominal obesity. It has a significant impact on hypertension. Whether that's a osmolality effect or whether it's a secondary effect, we can't quite tell yet. But it definitely has some benefit. And it increases the perception of energy. It increases the perception of alertness. So there's probably some significant factor that's more than just a single factor. So it's something that I'm looking forward to seeing how that goes. And I think that that's one of the coolest new things that's going to be on the market in the near future. I always get questions about apple cider vinegar. Does it work? What's it doing for me? It does probably reduce hyperglycemia, reduces the excursion that you see if you take apple cider vinegar and you're eating a bunch of sugar. It's a compound that is a derivative of basically vinegar. It's acetic acid. How it does this is it delays gastric emptying, and which then suppresses glucose production and increases glucose utilization. It probably has some benefit, and I know clinically that my patients do well with it, but I can't, and it does not throw them out of ketosis. It doesn't, because you would think it's an acetic acid, and acetaldehyde could end up in the cycle for mitochondria. It would do something, but it does not seem to throw my patients out of ketosis. It helps regulate blood sugar. And already we're transitioning these patients away from almost all of their refined carbohydrate and most of their non-refined carbohydrate. And most of our patients are on less than 20 grams per day. And so I don't really have any issues with them taking apple cider vinegar because it does not seem to make ketosis worse. And for some patients, it does seem to makes them feel better. The fact that it reduces gastric emptying is pretty significant because that's one of the methods that, and I'll talk at the end about Ozempic, one of the ways that Ozempic works is it reduces gastric emptying. It's not the only way, but it's one of the ways. Glutamine, I get questions about that every once in a while. It's a oxidative fuel. It's a precursor for gluconeogenesis, and it can benefit you. I have noticed, however, that patients that take glutamine, it throws them out of ketosis. And I've told them that, and I've seen it over and over and over again, because they'll take a glutamine supplement and they'll say, I've been told that I'm going to be okay with it. And it certainly improves gut health, and it improves feeding of certain sets of gut bacteria. But I've noticed in my clinical practice, supplementing with glutamine seems to push them out of ketosis almost in real time. And so I typically tell them to avoid glutamine supplements. And, every patient's a little bit individual, but that's what I've noticed in general in my practice. Phentermine is a prescription drug. It's a sympathomimetic amine. Phentermine historically has been used as a central nervous system stimulant. It's a scheduled drug. It works because it reduces the sensation of hunger. It increases the release of serotonin, and it causes a feeling of satiety and fullness. I use this as a bridge. It's kind of a harm reduction technique. You have somebody who has been trying to lose weight and they can't seem to do it, and they have all kinds of reasons why they can't do it. This is a good crutch. By itself, it's not going to do much. And unless you give them the strong dietary guidance, giving them phentermine by itself is just basically giving them essentially a weak amphetamine. It's not going to do much for them. But if you combine it with some re-education, it really does have a benefit. There is an antidepressant quality to it, and that's why it works in the serotonin system. There's a whole host of other drugs that you can use in supplementation with this. I usually use Therapeutic when I use phentermine. You put the two of them together, and it allows my patients to more quickly get into an area of ketosis more rapidly because they're able to control their dietary intake a little bit better. Therapeutic has a GABA-like activity. The main reason why Therapeutic works, it's used as an anti-seizure drug. We also use it for migraine headaches. I think the main reason why it works, though, is it's a weak carbonic anhydrase inhibitor. It makes all of these carbonated beverages taste terrible. And when they taste terrible, they're not drinking soda continuously. There is some benefit as in terms of the GABA activity, though, because that makes them feel calmer. And it antagonizes the glutamate receptor. So it makes them feel pretty good. And when you use it in combination, phentermine, that combination allows the patient to be calmer through the whole process, especially in the first 6 to 8 weeks when you're trying to get their diet regulated and you want to give them some wins. You want them to do well. Metformin is a drug that we've historically used. We use it in type 2 diabetes. And essentially what it does is it decreases glucose production in the liver. It effectively works in the gut microbiome, and it reduces the efficiency of fructose absorption into the liver. And it does that by changing the gut microbiome more than anything else. There is some evidence to support the fact that it increases peripheral sensitivity of insulin to the cells as well. We use metformin, but only in patients who are pre-diabetic, truly pre-diabetic, hemoglobin A1C greater than 5.6, 5.7. And I typically am taking patients who are on high dose insulin and supplementing them with metformin to get them off of their insulin, making them more sensitive. Thyroid supplementation. It's highly dependent upon the individual. There's not a one size fits all. And even if their thyroid is normal, even if their TSH is normal, there are circumstances where I would give somebody a thyroid supplement, but I would only do it within the context of I've tried other things first. One of the things that I find is that you'll find normal TSH, but their RT3 might be high. And so if the patient feels hypothyroid, if they tell you they're fatigued and I've eliminated all the vitamin B issues and all the other things, and I'm considering now doing a thyroid supplementation, I'll do thyroid antibodies and I'll look at their RT3. It's usually my next step. It's usually not my first step. And so hypothyroidism with a normal TSH and a normal T3 can still exist. It's something that you have to be sensitive to. So all of us know about Ozempic, and all of us know about glucagon-like peptides, GLP-1s, and glucagon receptor agonists. We've got a new drug on the block. It's a dual glucagon-like peptide and a glucagon agonist. It's survodutide. It has massive amounts of weight loss. And all of this is good. All of this is beneficial, only within the context, however, of teaching patients how to eat correctly. Because the thing is, if you give these patients, and I've seen it, if you give these patients this drug, which makes them stop eating, the second they get off of it, they rebound. And simultaneously with this, there is a hedonic component to the GLP-1s. It actually is, and we've seen this. We've seen it clinically, and I've seen it reported now quite a bit. If you take somebody who routinely takes a couple of drinks a night, and what I mean by a couple is like 6. I've had patients who have come in and they have alcohol use disorder. They don't volunteer it up front, but you find out that they've been taking 6 drinks a night. You put them on this drug because they're diabetic and you're able to get it approved. All of a sudden, they lose their hedonic drive to drink, and they're seizing because you got them off of their alcohol. And they have no desire to drink the alcohol because it's fulfilled their dopaminergic drive. And so you have to be very sensitive to it. At the same time, a lot of these patients become depressed because they become anhedonic. And when they get off of it, they seek out hedonic stimulus. It's almost akin to what you see with bariatric surgery patients. After a while, bariatric surgery patients become more likely to be alcoholics. They become more likely to abuse drugs because they're looking for ways to stimulate hedonic drive because they feel no affect, and they become significant risk takers. And it's something that clinically I've seen, and I've had a couple patients have significant issues with induced seizure from coming off of alcohol that we just didn't realize how much they were drinking. And so we've had to be more specific in our query with these patients. But I think that these drugs are worthwhile, with the exception of the hedonic drive, with the exception of you still have to educate the patient and teach them how to eat long term, and they can't be on these drugs for life. And the drugs are expensive. They're $700 to $800 a month. They're the cost of insulin per month. So you're replacing an insulin for this other drug that's glucagon-like peptide, and they're both expensive. And as soon as they come off of these, they rebound. But now when they rebound, they have sarcopenic wasting because they have lost all their muscle mass. And now you have somebody who is metabolically worse off than they started, and they have no basal metabolic rate, because that's where all of your basal metabolic rate lives, is in your muscles. And so now you're in trouble. It's something that I'm sensitive to, because these patients will lose their insurance. And when they lose their insurance, they lose their access to these meds, and they bounce like you wouldn't believe. And so these are the kind of the conversations that we have with them when we're talking about supplementation. Polyvagal theory. I didn't used to pay as much attention to this. And more, I'm paying more and more attention to it, especially when it comes to GABA. It basically says, the feeling of safety emerges from the autonomic nervous system. It's that feeling through your vagus nerve. And so we do everything we can to improve patients' vagal nerve function. And this can include everything from sound therapy using binaurals, everything from box breathing, stacking. You can even do peripheral vagal nerve stimulation. We actually have them through their little iWatch and have them measure their heart rate variability and teach them how to do breathing exercises. All of these things improve their sense of well-being, which then decreases their cortisol level, which then, as you decrease your cortisol level, improves the likelihood of you having success with your ketosis. We do a huge amount of feedback systems. My favorite feedback system is a CGM. Simply putting the CGM on somebody without giving them any instruction, just slapping it on them, will drop almost in real time, will drop their hemoglobin A1C. It'll in real time give them the feedback that says, hey, every time I eat a donut, my blood sugar is 250. And if I don't eat a donut, it runs 130. Maybe I shouldn't eat the donut. It's almost because the human naturally are inquisitive. And even if you don't give them any detailed information, except look at the blood sugar and see what it's doing. And that's usually my mechanism is, look, we're going to start you on a continuous glucose monitor because you're pre-diabetic. We're going to talk about this next week, but I want you to go ahead and use it. And I want you to understand what the information you're getting from it. And just simply doing that will get their morning sugars to drop. Simply doing that will, for a lot of patients, be enough of the feedback that it makes a difference. All of this is important. The weigh-in is really important, and the concept of self-distortion. I'll tell you that and we did the study in my clinic, 85% of patients lie to themselves about how tall they are. They all think they're 2 inches taller than they are. If you ask them how tall they are and you're doing telemedicine, you're going to get the wrong answer. You actually have to measure their height because they forgot that they shrunk. And you're basing a lot of your metrics, your BMI, if you accept BMI as a valuable tool, on a height-weight ratio. And if they're 2 inches shorter, that substantively changes their BMI, and it goes from maybe 29 to 34, which is a big deal. And so that self-distortion is a huge impact. And the lack of accountability by telemedicine is a problem. And so you really need accuracy in that piece of data. And a weigh-in is worthwhile. We do a lot of remote patient monitoring, and that weigh-in is really important in combination with a CGM is amazing. Hold on, I want to go back to one thing. Addictive eating and loneliness. I think that's where telemedicine really has a huge advantage as we build communities online and letting patients interact with each other in an appropriate way. That supporting mechanism is probably the biggest single thing that we can do to reduce addictive eating. And that support is really beneficial. And I think I've got a slide that goes on about that in a second here anyway. Circadian rhythms and restoration and time-restricted nutrition. You want to restore their circadian rhythm. And so we're very particular about sleep hygiene and blue light. And we're very particular about regimentation. We're very particular about you need adequate sleep in order to make this whole system work. And I'm not talking 6 hours, I'm talking like 8 hours. And so we're very, very particular, and we have pathways for them that we specifically discuss. And if you have adequate sleep, you're less likely to forage for food in the middle of the night. And if you have adequate true sleep and you're not taking a benzodiazepine, then you're probably not going to eat garbage. If you're taking a benzodiazepine, all bets off. You don't know what you're eating. And if you're on Ambien, you may be eating and not even knowing it. You may not have the evidence of it till the next day you wake up covered in Cheetos. And so that's something that you have to kind of keep in mind when you have discussions with these patients about sleep hygiene and getting away from the drugs that are amnestic for them and truly having sleep. Photobiomodulation, I did a chat on that earlier, but the key element is that infrared light is one of the critical elements that we're missing. And it's probably one of the most potent anti-inflammatory methods that we have for intramitochondrial production of melatonin. And we don't have enough of it in the United States because of our glazed windows and we're not outside. And so I'm pushing patients into green space every day. I'm pushing them into that sleep hygiene concept and waking up at the same time with or before the sun so that they spend the first 20 minutes in the sun and looking directly towards the sun so that they get those photoreceptors, one, to help them wake up, and two, they get the infrared light absorbing into their cells and start the day off the way that they're supposed to. And hopefully if you do it that way and you're not feeding them first thing in the morning and you're doing time-restricted nutrition, it all works out better for you. Heat shock proteins, sauna, cryotherapy, all of these have benefit. And in this field, we'll get those questions constantly. Does sauna help me? Does cryotherapy help? Yeah, all of these things help because they're hormetic responses. They're pushing your metabolism in a way that you're not habituated to. And anytime you do that, anytime that you're out of your comfort zone, it's going to benefit you. It's a hormetic response. And if you can have these hormetic responses, it'll make a big difference as in terms of metabolic flexibility overall. Mechanical things. Exercise is important. I usually recommend as much high intensity exercise in short bursts. I would rather have you do 30 seconds of as fast as you can go rather than, anything else as in terms of activity. So I recommend as much burst energy as you can get and then slow down, and then as much burst energy as you can get and then slow down. A lot of patients that I deal with are so wrecked as in terms of inflammation, they may not be able to exercise much at all. So we do things like vibrational plates. We do things like blood flow restriction bands. We do everything we can to improve their perception of exercise for their body so that the body tries to push it away from sarcopenic wasting. So like I said, supplements just aren't strictly medicaments. You can add things and you can delete things. And by deleting, you're actually creating a supplement. And so it's just a general overview. What's the missing thing? The missing thing is people. So there's a beautiful study out that shows that loneliness is more important than hemoglobin A1C, systolic blood pressure, depression, smoking, than as in terms of cardiovascular outcome. LDL-C, BMI, and albumin and GFR are important, but loneliness and the perception of loneliness is more important than the other ones. So that's something that is significantly missing. This was published in the European Heart Journal, and I think they had like 15,000 patients in the study. And that's in the notes section of these slides, if somebody wants to go back and look at the direct study. So it's not only important as in terms of how we function and how we get patients back from addictive eating, but I think that the concept of being lonely is also the avoidance of that loneliness is basically the Mediterranean lifestyle. It's not just the food that you're eating, it's the context of the people that you're with and those connections. And it's different than social isolation. Loneliness and social isolation are two different things. Social isolation could be voluntary, and you might be perfectly happy because you want to do something that you want to be socially isolated. But loneliness is that I wish I was craving and wish I was with people. That's a different concept. If anybody needs to reach out to me, just feel free to call, and I'm happy to chat. Thank you.